This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 941, recorded on September 29th, 2022. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today here at the incubator in New York, Daniel Griffin.
Hello, everyone. And hello, Vincent.
Hello, Daniel. How are you? Good to see you here.
I am doing well.
It's been a while since you've been here. Let me make
since I stayed.
Yeah, that's
I've
right.
come by and
that's
visited.
Right. You were here last week, and then you decided to leave. Before we get going, let me make two announcements. First, a research assistant positions available at the FDA in Amy Rosenfeld's lab. A focus of that research, which is at the Center for Biologics Evaluation and Review at the FDA, is to evaluate mechanisms by which cross-species anti-enterovirus antibodies may affect virus pathogenesis. And the research assistant will support work on picornaviruses like Entero D68, which you've heard about from Daniel, poliovirus, which you've also heard about from Daniel, human rhinoviruses, genetic, biochemical, cell-based studies for understanding multiple aspects of immune dysfunction associated with virus infection. The individual will carry out experiments in cell culture and participate in the development of small animal models for studying multiple aspects of infection, including the tissue-specific cellular immune response. All the work will be done at BSL-2 conditions. And then, of course, help celebrate the molecule of the year which is, of course, the spike protein of SARS-CoV-2, and support our work here at Microbe TV by going over to vaccinated.us, buying a T-shirt, and using the promo code Microbe TV on checkout. The promotion's been extended through October. Thanks to Matt for that. And they're also now including kids' T-shirts. So you can get your toddler a Spike T-shirt. How nerdy would that be? Okay, Daniel, it's all yours.
I just wish I had a toddler so I could get them a Spike T-shirt. All right, let us start with our quotation. "Why is it," he said one time at the subway entrance, "I feel I've known you so many years?" "Because I like you," she said, "and I don't want anything from you." And that's Ray Bradbury, Fahrenheit 451. And, Vincent, that made me think about this show, and it's a little bit sappy, so feel free to write in the emails. But no, I mean, I love getting emails from our listeners, and I feel like I know you. I think a lot of you feel like you know us. And over the last 2 years, I feel like we have this relationship. I was reminded of this. It's a privilege for us to be able to discuss science. Privilege for us, hopefully, to help you understand and get excited about science. Science has a PR problem, I hate to say, and we saw that the last 2 years. So hopefully we're making science accessible. We're getting you excited about science. This isn't a news station. This is a chance for you to learn, for you to get the science and hopefully feel good about that. So, all right up top, another reminder with the MMWR, increase in acute respiratory illnesses among children and adolescents associated with rhinoviruses and enteroviruses, including enterovirus D68, United States, July through September 2022. In short, what are we seeing? And I was just on a call with some of my colleagues earlier this week. We are seeing, and here in the MMWR, a rapid rise in the percent of emergency department visits associated with acute respiratory illness, for this time being higher than we have seen in several years. The reported percentage that are testing positive for rhinovirus, enterovirus are rising rapidly. I'd like to say that's not a new creature. It's just the primers will come up with this is either a rhino or an enterovirus, not really distinguishing it. But, and this is where I think this is critical, the percentage of those that are positive for EVD68 among children and adolescents with these acute respiratory illnesses and have a positive rhino-enterovirus PCR, this is now 56% during week 32. So this is now the majority of those rhino-enteroviruses are this EVD68. Now, why is that a problem? Well, the problem here is that previous increases in EVD68 respiratory illness have coincided with increases in cases of the acute flaccid myelitis that we've talked about. That's this neurological disease that affects the spinal cord. Per the CDC, clinicians should consider acute flaccid myelitis in patients with acute flaccid limb weakness, especially after a respiratory illness or fever, and ensure prompt hospitalization and referral to specialty care for such cases. Clinicians should also test for polio virus infection in patients suspected of having AFM because of the clinical similarity to acute flaccid paralysis caused by poliovirus. Now, I should mention that acute flaccid myelitis is something we even see in adults. I had a case of a man in his 40s, actually, and his children, but not his wife, developed AFM after an EVD68 infection. So something I think Vincent and Amy are quite familiar with.
It's a very interesting cohort because you would like to know why the wife didn't have a problem, right? And so studying them may provide some insight.
Yeah, I think that's should probably reach out to that man and connect him with Amy.
Yes.
Okay.
By the way, Daniel, the EVD68 AFM, we've not seen it in big numbers in the U.S. since 2018. We were expecting an outbreak in 2020, but because of COVID lockdowns and so forth, we didn't. And so now we're worried that this increase in respiratory infections will come with some more AFM. We're hoping that's not the case.
Yeah, I was abusing the other day. Remember when, it's just a virus was somehow reassuring. So polio, an update on polio. The positive polio wastewater sample that we heard about here in Nassau County appears to have come from, and they probably know exactly where it came from, but either from Port Washington, where I live, Roslyn, Manhasset, or Glenwood Landing, so really hitting close to home. But the message here is very simple. The polio virus is here. And the best way to avoid the risk of paralysis is to just get vaccinated. Living in a highly vaccinated community does not mean you are protected if you're unvaccinated. So children, go ahead. Pediatricians know exactly what to do. For the adult providers, there is an inactivated injectable polio virus vaccine. You get your first dose, you get your second dose a month later, third dose at about 6 months later. And as we've talked about before, there are some recommendations about a one-time booster, maybe 6 months after that. But really straightforward for the adult docs out there that are suddenly now hopefully getting requests from individuals who maybe were not vaccinated as children, but really want to get protected now. Influenza, timing matters. So most of us are suggesting that it's time to get those flu shots scheduled. Probably October is a good time to get that. And boy, that's right around the corner. Based on numbers out of Australia, we expect this to be the worst flu season in years. So let's do all we can to mitigate that. All right, monkeypox. As I've been saying for actually quite a while now, monkeypox is not a gay disease or an African disease. Monkeypox is an infectious disease. If you look at the monkeypox tracker, you can see that we're sort of sitting at about 200 cases a day. I ran into my buddy Jason Zucker the other day and, sort of celebrating. We're down to only 7 cases the other day here in New York City. Amazing that 7 cases in a day is an exciting number to be down to. But let me start with the dispatch estimates, early estimates of monkeypox incubation period, generation time, and reproduction number. Italy, May through June 2022. Everyone is sharing their information, their case series, so this is great. This was published in Emerging Infectious Diseases, one of my favorite journals. Based on a total of 255 PCR-confirmed cases that had been reported in Italy, we got a preliminary estimate of a mean incubation of 9.1 days with 5th and 95th percentiles distribution of between 5 and 23 days. So pretty long incubation period there. We also have the article, Monkeypox Virus Infection in Humans Across 16 Countries, April through June 2022, published in the New England Journal of Medicine. Here's an international case series of 528 infections at 43 sites in 16 countries. And this is used to describe the presentation, the clinical course, and the outcomes of these PCR-confirmed monkeypox virus infections. So as a caveat, and I think this is important, transmission was suspected to have occurred through sexual activity in 95% of the persons with infection. So this is important as we see more cases with different routes of acquisition, right? So this may be a little different depending upon the type of exposure. 95% of the persons presented with a rash, with the majority, 64%, having less than 10 lesions. 73% had anogenital lesions, 41% had mucosal lesions, with 54 having a single genital lesion. So sort of think about this when your radar's going up. Common systemic features preceding the rash included fever, only 62% of the time, lethargy, about 41%, myalgia, so the muscle pains, 31%, headache, 27%, lymphadenopathy was also common. About 56% of the cases is what they reported. Concomitant sexually transmitted infections were reported in 29%. So that seems to be a sort of fairly good number there. About 1 in 3 people also have something else going on. Hats off to John Hickam there. Among the 23 persons with a clear exposure history, the mean incubation period was 7 days. And we get the range, very similar, 3 to 20 days. The rest seems in keeping with what we are hearing from other smaller series. 70 people, or about 13%, were hospitalized. The reasons for hospitalization were pain management, mostly for severe anal rectal pain. And I have to say, this can be incredibly painful. Soft tissue superinfection, pharyngitis, limiting oral intake. And I discussed a woman that I'm currently taking care of who's hospitalized for that very indication. Eye lesions, and we have had some bad experience in the past in West Africa with those. Acute kidney injury, myocarditis, infection control purposes, right, trying to block that chain of transmission. In this series, no deaths reported. They've got lots of pictures, so a good place to go and look to educate yourself. Monkeypox transmission, this is predominantly through contact, as we've been discussing, and we keep getting that supported in the literature. No sex required. This is not a sexually transmitted infection. There's no sex required. That's just going to increase the amount of contact and the risk. Monkeypox testing, remember, do those 2 swabs, put them in the liquid medium, refrigerate or freeze. If you do not test, you're not going to get that positive test. You should have a lot of negative tests. If the majority of your tests are coming back positive, you're not doing enough tests. Monkeypox vaccines, we got them, and I will already give you a sort of teaser for next week. Next week, we're going to talk about some fresh data. Do they work? And as far as monkeypox clinical course and treatment, we're mainly talking here about TPOX, but those viroptic eye drops, the trifluoridine eye drops, if we're worried about eye involvement, and continued a little shout out for the A5418 study of tecovirimat for human monkeypox virus, the STOMP trial. So for more information, I have to say, if you've been diagnosed with monkeypox, if you've diagnosed someone with monkeypox, those 200 folks that are getting diagnosed per day, let's get them all enrolled in this trial. And we will share a link, www.stomptpox.org/Bain. Columbia is one of the sites, and my friend Jason Zucker is helping us here enroll patients. This is not just for severe. Anyone with monkeypox can enroll in this trial. So a call out to our listeners. We have sites in Texas. We have sites in Florida. We have sites here in New York. So this is one of those, stop the recording right here if you have had the diagnosis, if you've made the diagnosis, and let's get people enrolled because we really need the science here. Remember, this is a therapy with a low barrier to resistance. We really need to know who needs it, who doesn't need it, what's the timing, what's the impact. All right, COVID. I wanted to put this peer-reviewed journal article right up front. Rapid increase in suspected SARS-CoV-2 reinfections. Clark County, Nevada, USA, December 2021, published in Emerging Infectious Diseases. I still remember a podcast. I don't want to give too much air to the podcaster, but I still remember him with a guest, and the guest kept saying, no, you're mistaken there, sir. You can only get COVID once. No, I understand all your friends think they got it a second. It's not true. Well, I think it's now clearly true. I was reading a book by someone that I really respect that just came out in print, and right in the introduction was this false idea that getting COVID or getting a COVID vaccination would then remove a person from the chain of transmission, and eventually the coronavirus would run out of people to infect. There certainly were some people that pronounced early on that reinfection with SARS-CoV-2 was just not possible, and if you thought it was, you were just mistaken. Well, this article looked at reinfections defined as a second positive PCR test collected greater than or equal to 90 days after an initial positive test. They calculated the proportion of all new cases per week that were suspected reinfection and rates per 1,000 previously infected persons by demographic group. So initially, the rate of suspected reinfections remained less than 2.7% until December 2021, and then increased to about 11%. So about 1 in every 9 infections are reinfections, a person getting infected another time. This did correspond with local Omicron variant detection. And then reinfection rates were higher in certain populations, particularly, interesting enough, adults in the 18 to 50 years of age. Women and minority groups, especially persons identifying as American, Indian, Alaska Native.
Are any of these individuals vaccinated, Daniel?
No. These are actually people who are foregoing that wonderful intervention. All right. I will make sure I check on that. All right. Children, COVID, and other vulnerable populations. Children are at risk from COVID, as I've been stating for quite a while. But vaccines are complicated for kids. But we have heard that mid-October, there might be an approval for bivalent boosters. Friday, September 23rd, Moderna requested emergency use authorization of its updated vaccine in 2 age groups, adolescents aged 12 to 17 years and children aged 6 to 11. The application for the bivalent vaccine for children between the ages of 6 months and under 6 years is expected to be completed later this year, the company said in a tweet. Okay. And Pfizer asked U.S. regulators Monday, 9/26/22, to expand use of its updated COVID-19 booster shot to children ages 5 to 11.
So in this paper, which you just talked about, additional data of interest, including vaccination status, were not available for this analysis.
Okay, excellent. Well, not really excellent, but yes. Okay. It would be nice to have that in there. Because I think, as we keep pointing out, getting a vaccine is not going to guarantee that you're not going to get infected or even reinfected. So, all right. Use tests intelligently. And remember, there's more out there than just COVID. And as I like to say, have a plan. This is the time to have a plan before you end up with COVID. We got an update from the CDC, Interim Infection Prevention and Control Recommendations for Healthcare Personnel during the Coronavirus Disease 2019, COVID-19 pandemic. This was updated on September 23rd, 2022. This will have some implications, or it seems to be having implications for providers, facilities, and patients. It does look like it's part of a shift that really seems to be acknowledging that zero COVID is not a goal, that COVID is really here to stay. It starts with a long bulleted list, and there's a lot of details. So for those interested, I will leave the link. COVID active vaccination. Never miss an opportunity to vaccinate. Vaccinated people still get infected. They're just less likely to die or have severe disease. This is where I should tell the story. My wife just recently took Barnaby for a trip. Barnaby's my son. I was going to say my youngest, oldest. He's my only son. And they were going to be gone for 4 days. And before she left, she leaves a couple, by the way, make sure you feed the dogs. And by the way, I'm only gone for 4 days. Don't get vaccinated while I'm gone. I don't care if there's some new vaccine. You can wait and discuss it. Apparently, I'm so excited about vaccines that she needs to warn me. Okay. As they say, repetition is critical in teaching, and I'm hoping to keep reinforcing the concept that while protection against severe disease appears to be durable, protection against infection with SARS-CoV-2 vaccination is transient and fleeting and temporary. The research paper, SARS-CoV-2 secondary attack rates in vaccinated and unvaccinated household contexts during replacement of Delta with Omicron variant Spain, was published in Emerging Infectious Diseases. These are the results of a prospective cross-sectional study of household contacts of symptomatic index case patients with SARS-CoV-2 infection during the shift from Delta to Omicron dominant variants in Spain. They included 466 household contacts from 227 index cases. The secondary attack rate was 58.2% during the Delta dominant period and 80.9% during the Omicron dominant period. During the dominant period, it's kind of a tongue twister, the Delta dominant period, unvaccinated contacts had higher probability of infection than vaccinated contacts with an odds ratio of 5.4, very exciting, but this effect disappeared at about 20 weeks after vaccination. So this is where people keep asking, oh my gosh, 20 weeks, what, are we supposed to get vaccinated every 5 months? I'm okay with that. I'm not sure everyone else is. All right. I think with the timing, this is the episode that will drop the day before Paul Offit comes on as a guest on TWiV, Vincent?
That's correct. Yes.
All right. So tomorrow Paul Offit will be recording, and when you listen, it'll be tomorrow that episode drops. I'm looking forward to his appearance. And I'm a bit concerned that his comments are being taken out of context. So I think it's really ideal that he's on TWiV, where I think he'll be given the time and the context to really communicate the science. As mentioned, I'm a bit more bullish on vaccines and boosters, as our listeners probably know, as does my wife. But I just wanted to share a link to the CDC data on unvaccinated, fully vaccinated, vaccinated with a primary series plus 2 boosters with regards to deaths. And maybe we can paste this in our show notes along with the link. But it really points out that, wow, those first 2 shots is where we see this dramatic reduction, this 90% reduction in the risk of severe disease, hospitalization, death. We do get a little bit of further benefit when we start throwing boosters on there. But as I always point out to people, if your risk of ending up in the hospital and dying is 0, well, 0, 50% reduction is still 0. So I think there is an important discussion here. If you're an older individual, if even that 90% reduction is still giving you a 5, 6, 10% risk of ending up in the hospital, if you can get another reduction, that becomes much more meaningful. So I do think that it is reasonable to have this discussion. I don't think we need to be tribal about this. I think it's reasonable to have a discussion. And we're going to even discuss coming up, when should you get that booster if you should be getting it? All right, so the publications, going to be 2 here. The first is breakthrough infection by SARS-CoV-2 Delta and Omicron variants elicited immune responses comparable to mRNA booster vaccination, published in JID. And I think this makes for good discussion. The data here is supporting the idea that an infection might be the immune equivalent of a booster shot. So here is data presented as well as reference to other published data suggesting that both Delta and Omicron infection after vaccination elicited markedly high levels of serum total RBD, so receptor binding domain immunoglobulins and neutralizing antibody, as well as T-cell responses in individuals who previously completed 2-dose vaccination. The levels of immune response were comparable to those receiving the heterologous mRNA booster vaccination. I'm always hesitant when I share data like this. I never like the description of natural infection. I mean, natural infection in the Hobbesian sense, like a natural shark bite. Getting infected has all the associated risks. It's not a nice way to get that immunity. But I think we're starting to see the science here. So don't go out and have an infection party. That's not the safest way to go.
Of course, Daniel, they're looking at antibodies, neutralizing antibodies, and they're not looking at disease in any way, T cells. So we don't know what this actually means in terms of protection against severe disease.
Yeah, I mean, they did do some T cell stuff, but I think that's really critical. We don't have the data the way we do with the vaccinations on protection against severe disease and death. Yeah. And that's really what I sometimes worry we think we're smarter than we are. We look at these antibodies. We think we know what to make of them. We look at T cells again. We think we know what that means. Yeah, I was having a discussion today that I entered medicine when evidence-based medicine was considered as offensive as hand washing. And it was this whole idea, I think we've discussed, that apparently a well-controlled trial was more persuasive than a seasoned physician and 30 years of confirmation bias, right?
In my experience, right?
In my experience, the 3 scariest words in medicine. All right. And now I want to bring this all together with the article, Interval Between Prior SARS-CoV-2 Infection and Booster Vaccination Impacts Magnitude and Quality of Antibody and B-cell Responses, recently published in Cell. And it all is kind of in this graphical abstract that we'll post in a link, and we'll sort of discuss briefly here. But again, it goes back to this concept: is it all about antibodies? And they look here at people that were uninfected and then got their booster. They looked at people that got infected and then they boosted them within 180 days compared to those who had an infection more than 180 days prior. And then they looked at people who were boosted and then infected. And one of the things sort of in the center of this graphic is people that had an infection in the last 180, so the last 6 months, then got a booster. You really didn't see much happen to the antibody levels.
It's interesting because the previous study, an infection does, at least in terms of antibody responses, does appear to be the equivalent of a booster.
Yeah, I think what they have to do in that first study is look at the timing. When was that infection relative to the timing? So if you got your boost, let's say, or your prior vaccine, and you get infected a month later, does that do much? Does that give you extra? Does it count as a booster, or do you need to have a certain amount of time from your vaccine? So I do think there's a lot here more we need to learn.
Also, the order is different. In the first study, it was vaccination and then infection. Here, it's infection, then boosting. So maybe that makes a difference, right?
Yeah. And I do, unfortunately, most of us will at some point get infected. So at least the growing science suggests it's nice to have that vaccine first. So if you're still out there, if you're unvaccinated, if you've never gotten COVID, now's the time to get vaccinated. The window's closing. All right, COVID passive vaccination, Evusheld, right? This is that product where we give you those antibodies authorized for use in adult and pediatric individuals down to 12 years of age. I hope the pediatricians are taking note of that. So even your high-risk teenagers, those who have immune compromise, just think about this as an option. But I do want to discuss the correspondence, further humoral immunity evasion of emerging SARS-CoV-2 BA.4 and BA.5 subvariants was published in The Lancet. So here the background is that multiple BA.4 and BA.5 subvariants with this arginine 346 amino acid substitution. They used a different word there, but I corrected it. In the spike glycoprotein have been identified in various countries. And what are these? So there's the BA.4.6 thrown in there among others. And I previously mentioned the BA.4.6. Lots of data here using a pseudovirus neutralization assay. But while bebtelovimab still appeared effective, that's our therapeutic monoclonal antibody, there were concerns about the passive vaccination with Evusheld losing efficacy. And maybe this is time for us to revisit the variant tracker. Is the BA.4.6 something significant? Well, it is rising in our local area, but the Region 7, right, that's Iowa, Kansas, Missouri, and Nebraska. Don't worry, I don't have those memorized. There, the BA.4.6 is actually up to between 14 to 29.5%. So really rising in that area. It's over 10 to 15% here in the New York tri-state area. So definitely a concern for those that we're trying to protect with passive vaccination. All right, COVID, the early viral upper respiratory non-hypoxic phase, that first week, the order is the same. And really, I guess what I'll say is if you're listening, if you're a clinician, if you treat COVID patients or you know someone who does, You pause, have them pause, jot this down. This is my recommendation. This is the NIH recommendation. This is the recommendation from the ID Society of America. These are the professional recommendations that are data-driven. Number one, Paxlovid, about an 89 to 88% reduction in progression to hospitalization and death. I don't care about the rebound or anything. What we're doing is we're trying to keep people from dying. We're trying to keep people out of the hospital. We have 400 to 500 people still dying per day. If we give all those people Paxlovid, right now, what is it, about 1% are actually getting, 1 or 2% are getting treatment, we can instantly take that 500 and drop it to about 50 or 60. So number one, Paxlovid. Number two, Remdesivir, early 3-day IV. We have data demonstrating an 87% reduction in progression if given in the first 5 days. So if your loved one, if you end up hospitalized, people do end up hospitalized in the first 7 days, Remdesivir, 3 days of Remdesivir is a perfectly reasonable, appropriate, recommended therapy. And I will talk about the article, Short Course Early Outpatient Remdesivir Prevents Severe Disease Due to COVID-19 in Organ Transplant Recipients During the Omicron BA.2 Wave. This was published in the American Journal of Transplant. So these are the results of a prospective cohort study in outpatient adult solid organ transplant recipients during the Omicron BA.2 wave, so April through May of 2022, to determine the effectiveness of the 3 doses of Remdesivir given within 7 days of symptom onset. Patients were followed for at least 30 days. The primary outcome was hospitalization of 210 solid organ transplant recipients that had COVID-19. They included 192. The most common transplant was kidney, that was 41.7%, lung, that was 19.3%, liver, that was 18.8%, heart was 6.3%. So most patients, over 90%, had previously received at least 3, so 3 or more COVID-19 vaccine doses, right? So a lot of clinicians I know are out there saying, oh, you've been vaccinated, I'm not worried about you. The adjusted number needed to treat to prevent 1 hospitalization was only 15. There was an 88% reduction in the hospitalization rate, so an adjusted hazard ratio of 0.12. So no patient that received early Remdesivir needed ICU admission or died. So just more and more evidence. I know a lot of clinicians out there, you're probably going to be okay. Well, the 99% of those 500 people that died may have been given that message, and for them, it was not okay. Monoclonal therapy, now we have bebtelovimab and the encouraging data that this is going to continue to be effective even with BA.4.6 increasing. Some evidence that it's only slightly inferior to Paxlovid. So I do want to point that out. The data we have head-to-head suggests that it is not superior, not equivalent, but slightly inferior. All right, Malnu Piravir. This is, we talk about our last option. It's nice in that we don't have drug-drug interactions, no renal issues, but remember, be careful in women of childbearing age, not authorized for those under 18. You want to get that negative pregnancy test if you're going to be using it in a childbearing age population. The article, Effectiveness of Malnu Piravir in High-Risk Patients, a Propensity Score Matched Analysis, was recently published in CID. So these results are based on the database of the largest healthcare provider in Israel. People may know the name of them by now. They looked at adults with first ever positive tests for SARS-CoV-2 performed in the community during January through February 2022, who were at high risk for severe COVID-19 and had no contraindications for Malnu Piravir use. Patients were included regardless of SARS-CoV-2 vaccination status. A total of 2,661 patients who received Malnu Piravir were propensity score matched with 2,661 patients who had not received Malnu Piravir, so that's our control group. Patients were followed through 10 March 2022 for up to 28 days from the first occurrence for the composite severe COVID-19 or COVID-19 specific mortality. So now what did they find? Everyone's on the edge of their seat. The composite outcome occurred in 50 patients in the Malnu Piravir group and 60 patients in the control group. Malnu Piravir was not associated with a significant reduced risk of the composite outcome. We have overlapping confidence intervals here. They did then go on to do subgroup analysis that suggested that Malnu Piravir was associated with a significant decrease in the risk of the composite outcome in older patients. There they're seeing 0.54, so a 46% reduction. Interesting enough, in females, 0.41, so a 59% reduction. And I think this is interesting, in patients with inadequate COVID-19 vaccination. And that was 0.45, so a 55% reduction. And I will point out, what was their definition of inadequate vaccination? This included people whose last vaccination or booster dose was greater than 100 days prior. Interesting. Okay. Moving on to don't do harmful things. And I think I can leave it at that. I think we know what those harmful things are. All right. COVID, early inflammatory, lower respiratory hypoxic phase. This is often when those folks end up in the hospital. What defines hypoxemia? It's been shifted in a number of different studies. Is it 94? Is it 92? It's always less than 90% in all the different guidance. Number one, steroids at the right time, in the right patient, at the right dose. 2, anticoagulation, again, dose adjusted based on your specific patient. 3, pulmonary support. 4, maybe Remdesivir if you're still within the first 10 days. Not if you wait too long and they end up on a ventilator. Not as effective as we talked about in that first week. 5, immune modulation. That's our tocilizumab, our IL-6 receptor blocker, and in some cases, baricitinib. And then 6, avoid those unnecessary antibiotics and unproven therapies. Moving on to COVID, the late phase or PASC. Actually, I feel like this was a good week for folks here. The article, Long COVID, an update for primary care, was recently published in BMJ. And I am going to recommend that all providers, not just people who take care of people with long COVID, we all take care of people with long COVID. Take time to read this article. It will not take a tremendous amount of time, and I do think that that time will result in a benefit for patients that are under your care. May even help you to recognize that these patients are under your care. They start with an updated definition. The term long COVID refers to prolonged symptoms following infection with SARS-CoV-2 that are not explained by an alternative diagnosis. It embraces the NIH and Care Excellence, NICE terms, ongoing symptomatic COVID-19, so symptoms lasting 4 to 12 weeks, and post-COVID-19 syndrome, symptoms beyond 12 weeks, the US CDC-P group of post-COVID conditions, and the WHO's post-COVID-19 condition. They reference the data that rates of long COVID are lower in people who are triple vaccinated, but prevalence of long COVID, persistent symptoms at 12 through 16 weeks after laboratory confirmed SARS-CoV-2 infection remains high at 5% for the Delta variant and 4.2 for Omicron BA.2. I'll put in a link to the UK data they reference on this, but even though the absolute percentage might only be between 1 to 4%, there are a number of studies showing a lower risk of long COVID after 1 dose, lower with 2, and then a little bit lower with that 3rd dose. Percentage of study participants, and we have a link that we'll post in, looking at COVID based on vaccination status, based on types of symptoms. And this is
glad to see that we've come down from 50% incidence of long COVID that some studies were reporting, right?
Yeah. All right. They next discuss the different symptom clusters, right? And I think we've talked a little bit about this. All long COVID is not the same. There tend to be different symptom clusters, and that actually helps us as clinicians as far as guiding what therapies we might consider. And then they actually go through a list of things that physicians can do, which include, I'm going to just mention a few of these because we can do things. Don't just throw up your hands. 1, hearing the patient's story and validating the experience. That is critical. 2, making the diagnosis of long COVID. which does not have to be by exclusion. You want to make sure there's nothing else, but then you also want to make the diagnosis. Providing holistic relationship-based care through continuity of care with a sympathetic, they say clinician, I'm going to say provider who knows the patient. And then they focus on managing specific symptoms. And there's a table 1, really nice table. And you can go through what symptoms, what's bothering you, and it goes through different suggestions on what you might want to do. They also talk about detecting and acting on red flag symptoms. There's a nice infographic there. Managing those comorbidities, right? Diabetes, cardiovascular disease. And then I think this is really important, helping set realistic goals for recovery. 95% of these folks are getting better, but they have to understand this is not going to be a wake up the next morning and be better. This is going to be gradual. There'll be 2 steps forward and then 2 steps backward. There will be a waxing, waning, and I think it's important to be realistic. They do talk, and I think this is really critical, of referral to other members of the primary care team. Get your pharmacist, your advanced clinical practitioner, your specialist, your social support services, and then follow them over time. So monitor the progress, assess their mental well-being, manage depression, anxiety, other things that are either driving this or resulting from this. Really, really practical advice here. So I do encourage everyone to take a look there. All right. I'm also going to put in, as we wind down here, a plug for a recent episode of Febrile, Sarah Dong's podcast. The title, A Mischievous Case, gives it away, but it's a nice exploration of a case of multisystem inflammatory syndrome in children. I know there's still significant hesitancy out there regarding childhood vaccinations for COVID, but I want to say this is very sobering. They actually quote here that 8,600 confirmed cases of this multi-system inflammatory syndrome in children have been confirmed by the CDC. So thousands of children going through this. Just compare that to the safety and efficacy of our vaccines. Remember, this is a vaccine preventable issue. And our final article for today, a distinct symptom pattern emerges for COVID-19 long haul. A nationwide study was published in Scientific Reports. They have a really nice graphic, and it really is, I think, helpful for us as clinicians to understand the timing, what patients might be going through, when to expect that. It starts off with acute COVID, fever, chills, maybe cough, sleeping more than normal, fatigue, headache, the viral phase. Then it moves into the difficulty breathing, that second week. But then it moves into the third week when we start to see some confusion, joint pain, dizziness, the heart palpitations, tachycardia, blurry vision. So just a really nice study looking at what we've been seeing, this progression over time. And I close, as always, no one is safe until everyone is safe. I want everyone to pause the recording right here. Go to parasiteswithoutborders.com and click the donate button. Even a small amount helps for us to continue to do our work. We are right now in the middle of our Floating Doctors fundraiser. So during August, September, which is almost over, and October, donations made to Parasites Without Borders will be matched and doubled by PWB up to a potential donation of $40,000 for the tremendous work that Floating Doctors does down there in Panama.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Adrian writes, if we decide to get the bivalent booster, how important is the timing? My wife saw an article claiming you shouldn't get it sooner than 4 months after a previous COVID infection because the body won't develop a strong immune response to the shot. But I recall guidance on TWiV that people could get the vaccine a few weeks after infection. So does timing matter?
Yeah, I think as we're learning more and as things are changing with the pandemic, and I'll say what I mean by that, our advice, our guidance is evolving with the knowledge. Early on, when we had people completely unvaccinated and they would get an infection and we kept having this variant, that variant, people were getting infected 30, 45 days after the first infection. We were saying, listen, once a couple weeks have gone by, if you're unvaccinated, let's get going. Let's start that vaccination series. And I still feel the same way about the unvaccinated. If you got your infection, maybe that's the wake-up call. Maybe it's time for you to jump on board. But as we discussed today, if you're an individual, you've gotten 3 shots, let's say, 2 shots, you just got an infection in June. So here we are, July, August, September. I'm counting on my hands, 3 months out. I'm not sure that that booster is going to do a lot for you. 1 month, 2 months, 3 months. Start thinking about timing. We think that our boosters are going to give us protection against infection for a limited period of time. We talked about that being 20 weeks or less, maybe diminishing a little bit over time. We don't know yet how much that's going to add to moderate severe disease, hospitalization. So again, that's going to come down to your risk factors. So if you're a 91-year-old gentleman carrying extra weight, number of health issues, then 3 months might seem reasonable. But now we're starting to get into areas where we know that the sooner you get that, you may not get that antibody response, which is actually what all the data was prompting us to go forward with these boosters.
Anthony writes, I just received my bivalent booster of COVID-19 vaccine, but I'm also prescribed hydroxyzine for anxiety and was wondering if you knew anything about antihistamines reducing the efficacy of a vaccine because of reduced inflammation and thus reduced immune activation.
Yeah, I would sleep well, which maybe hydroxyzine will help you do. No, I'm not particularly concerned that that's going to have a significant impact upon your vaccination.
Bradley writes, love your podcast. This is my question. I was told I should wait at least 14 days after taking COVID-19 booster before taking a live vaccine. Could you explain this waiting period versus vaccines that are given simultaneously? I had the opportunity to take my first Jynneos intradermal vaccination at a festival in San Francisco this last weekend, so I did, even though I was only 10 days post-COVID-19 booster. It was convenient, no waiting in lines. Do I have anything to worry about? I'm 63. I'm sure I had dry vax when I was young. I had quite an injection site reaction.
Yeah, I mean, in this situation, I don't see a problem. And we've talked a little bit about recommendations of the timing. We're, interesting enough, prioritizing that monkeypox vaccine. But here's the situation you described. You got your booster, and then boom, suddenly there's this opportunity to get your Jynneos monkeypox vaccine. Fine, go ahead, get that monkeypox vaccine, get another dose 4 weeks later. I do not think that COVID vaccine is going to reduce the response, reduce the protection that you're going to get.
Erica writes, I want to thank you and Dr. R for the incredible service. I teach undergraduate medical and molecular virology at Colorado State, Fort Collins, with Tony Shounts, who's been on TWiV, of course, and who I saw recently. And by the way, Erica, Tony was saying, I have to start working on the course with Erica at the time of that meeting. I'm curious if you have any clinical experience with patients who have mast cell activation syndrome and COVID. I was originally diagnosed with mastocytosis. They later downgraded to MCAS. I'm very well controlled with lots of H1 and H2 antihistamines and Elmiron without having to take cromolyn. I have read that patients on the mast cell stabilizers are less likely to progress to hospitalization. I know that famotidine has been correlated with better outcomes. I'm on high doses of that. What I cannot find any information on is, do people with MCAS have to be more concerned about long COVID? And she goes through some publications. So I'm curious if you're seeing any MCAS patients, if they're more likely to develop long COVID.
Yeah, so I see a number of patients who have this, and you're really describing the treatment paradigm that we approach. So the high doses of the different antihistamines. I'm not sure how much I can add to what you brought in. There was some early excitement, I'll say, that famotidine would be this early treatment for COVID. I'm not sure that ever really panned out. I mean, if you looked at 1,000 variables, you could find 12 that looked interesting. Data mining, in my opinion. There also was a lot of interest in the idea that maybe a subset of people with long COVID, of PASC, actually have developed this mast cell activation syndrome. And there is actually, as you'll see in some of the literature, a subtype which really looks like we call it a allergic subtype, an antihistamine responsive subtype. So I think there's still quite a bit here to learn. But yeah, keep my radar up. As we learn more, I'll definitely share information on this.
William writes, I've heard some talk about using high-dose influenza vaccine in immunocompromised patients under 65 years old. Is this a good idea?
Yeah, this is interesting, actually. And, so as our listeners may or may not be aware, this is the first year that the CDC has come out with preferential recommendations on the vaccines. Basically saying, hey, people over 65, these are the ones that are studied. These are the ones that we recommend. About a year ago, we had a discussion. I think we discussed the data on TWiV, where the cell base, or the flu cell vax, if you look across the entire population, tended to be more effective. So what we're doing, I know as an organization, is all the way across the board, we're recommending the cell-based flu cell vax. But then when people get over 65, we're recommending those high dose, sort of the double dose egg-based, and some of the others out there. They're not approved for under 65. So what I'd say for folks under 65, look for that flu cell vax.
And finally, Carol says she's making a plan, as you have suggested, and she wants to get Paxlovid from her primary care physician. But the physician says before you can do that, you need to get a creatinine test, which she said is very expensive, and wants to know if it's really necessary before you get Paxlovid.
Yeah, I mean, it is actually. It's important to know the renal clearance, the renal function, and that creatinine test is how we know that. So yeah, I do sort of apologize for our broken healthcare system, but no, it is critical to know kidney function for your clinician to safely use Paxlovid.
That's TWiV Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you, and be safe. And Vincent, you be safe too.
I will.